I want to talk now about out-of-hospital cardiac arrest with a focus on Cath timing and indication. Just some reminder of basic prognostic ideas you need to know. Of 100 patients suffering from out-of-hospital cardiac arrest, about 10% survive to hospital discharge, 8% with good neuro and functional status. This is more so if you have VFib, VT as initial rhythm, up to 30% survive to hospital discharge with decent neurological status. With PA arrest, 10% survive to hospital discharge. Worse if PA is from primary cardiac failure versus PA from metabolic respiratory causes. And asystole, that has the worst prognosis, only 2% survive to hospital discharge. And if you have unwitnessed asystole with delay to CPR more than 10 minutes, practically 0% survive to hospital discharge. Some patient with non-shockable initial rhythm, PAA or asystole, develop VT VFib during the course of resuscitation, but they should still be considered as non-shockable rhythm for the purposes of prognosis and downstream Cath therapy. We use initial rhythm for prognostication. Prolonged VFib inherently eventually progresses spontaneously to asystole, in which case it has very poor prognosis, as poor as initial asystole. Now, VT VFib doesn't usually progress to PEA spontaneously. It progresses to asystole, not usually PEA. However, it can and commonly does progress to PEA after shock, and usually wide and slow PEA. And that post-shock PEA is at least as bad as initial PEA, initial primary PEA, because at this point, that post-shock PA is a manifestation of end-stage pump failure from the ischemia incurred by the VT VFib. So the shock eliminates VT VFib, but leaves you with that massively failed pump that cannot generate any blood pressure, hence the PA arrest. So that PA is as bad as initial PA from cardiac failure. And notes about PEA. Primary PA arrest, which means PA as a true initial cardiac arrest rhythm, is sometimes caused by reversible metabolic or respiratory causes or massive bleed, PE, tamponade, the so-called 5H and 5T, in which case the PA rhythm usually progresses from sinus tachycardia to bradycardia. But keep in mind, the most common cause of primary PA arrest, meaning your first cardiac arrest rhythm is PA, not VFib. This is primary PA arrest. The most common cause of that primary PA arrest is actually severe primary cardiac failure, more than those metabolic respiratory causes. And it's primary cardiac failure, whether from advanced heart failure or massive global primary myocardial ischemia, for example, severe acute left main ischemia or acute MI on top of prior severe LV dysfunction. Cases in which the outcome is very poor. So primary PA arrest from severe primary cardiac failure, the outcome is very poor, probably less than 10% survival to hospital discharge. In fact, PA is a common mode of death in patients with ICD. They develop PA as a primary mode of death or as a rhythm after ICD shock. And the second most common cause of primary PA arrest after primary cardiac failure is probably hypoxemia respiratory event. Then you have all the other metabolic causes, tamponade, PE. PA may also occur, as I mentioned, as secondary rhythm after VFib shock. Now, this is a very important slide that you need to know. It's a summary slide that I made based on the data. What are the causes of cardiac arrest according to the EKG in a patient without obvious non-cardiac causes of arrest? So whether you have VT VFib out of hospital cardiac arrest or even PA asystole without obvious non-cardiac causes, 1/3 of patients have STEMI on the post-arrest EKG and 2/3 have no ST elevation on post-arrest EKG. Now, when you have a STEMI on post-arrest EKG, the most common cause overwhelmingly is acute coronary occlusion. in up to 90% of the time, but not always. Even when you have STEMI on post-arrest EKG, about 10 to 20% of patients don't have acute coronary occlusion. And their ST elevation is actually secondary to the arrest itself. And that ST elevation would be a transient ST elevation that resolves within 8 to 30 minutes. Or it could be ST elevation from potassium, PE, or intracranial hemorrhage, as one Korean registry has shown, intracranial hemorrhage. So it's not always acute coronary occlusion, although overwhelmingly it is so. Now, 2/3 of patients with VT, VFib arrest or PA asystole without obvious non-cardiac cause do not have ST elevation on the post-arrest EKG. Even if you don't have ST elevation on post-arrest EKG, 65% of patients have CAD. So still overwhelmingly, the most common cause of cardiac arrest, even without ST elevation, is CAD. However, most of the CAD, when you do not have ST elevation, most of the CAD is chronic or old CAD with ischemic cardiomyopathy, SCAR, and sometimes Q-wave. This is what we call SCAR VFib. And based on the COACT trial, only 20% of those VT VFib with no ST elevation on post-arrest EKG, only 20% have an acute lesion. 65% have CAD, but 20% acute lesion and only 5% acute occlusion. The other 15% were what they called unstable lesions, non-occlusive though, non-totally occlusive. They were more than 70% obstructive with evidence of either thrombus or plaque irregularity, but non-totally occlusive. The acute lesions were 39% in TOMAHAWK. And further evidence of this CAD being in all CAD is that a substantial proportion of patients had prior PCI or CABG, and a substantial proportion, 37%, had CTO. So even though the most common cause is still CAD, it's more an old CAD with a SCAR, ischemic cardiomyopathy, frequently Q waves, not acute coronary lesions. And those numbers are based on those data. Okay, so please know this slide very well. It's the most important slide of this talk. So I will discuss, should you do immediate cath in those patients with ST elevation? Should you do immediate cath in those patients without ST elevation? Let me start with those. Immediate cath in patients with no ST elevation on post-arrest EKG. Two major trials published in New England Journal of Medicine, COACT and TOMAHAWK, showed no benefit of immediate cath when you have no ST elevation versus delayed cath more than 24 hours, meaning delayed cath until neurological recovery, usually few days, as per COACT trial. Both those trials selected deeply comatose patients with GCS score of 3 who were successfully resuscitated after out-of-hospital cardiac arrest. COACT only included initial shockable rhythm, while TOMAHAWK included shockable rhythm or non-shockable rhythm, as long as no obvious extracardiac cause of arrest. 90-day survival and survival with good neurological status was similar between the immediate versus delayed cath. It was 60% in COACT, 40+% in TOMAHAWK. Those are good numbers because those trials selected patients with good neurologic features, except for being comatose, but good other neurologic features. And there was no benefit of immediate coronary angiography, even though the trials both selected patients with some favorable feature for neurological recovery, except for being GCS3. In both trials, it was mostly witness arrest, 80 to 90%, with only 2 minutes time to initiate CPR, and time to return of spontaneous circulation, 15 minutes, pH 7.2, lactate, post-arrest of 5. Now, why wasn't immediate angiography beneficial in those patients? Because even though 65% of them had CAD, only 20% had acute lesion in COACT and only 5% had acute total occlusion. And presumably 39% acute lesion in TOMAHAWK, even though they don't elaborate how many were occlusive or how they defined acute occlusion in that study. So I would go more by that number, 20% with 5% total occlusion. And the reason the immediate angiogram wasn't beneficial is one, not many lesions were acute, and number two, even in the carefully selected COACT and TOMAHAWK trial with some favorable neurological features, death was eventually dictated not by cardiac failure, but it was dictated by neurological anoxic brain injury. 65% of death were due to that, or by sepsis multi-organ failure, 12%. And only a minority died because of cardiogenic reasons, 15 to 25%. So therefore, Cath cannot help with those multi-organ failure and anoxic brain injury, and that's why it's hard to show a benefit from Cath in those patients. Another comment here about cardiogenic shock post-cardiac arrest. Both trials, COACT and TOMAHAWK, excluded severe cardiogenic shock post-arrest, presumably so. However, if you look at the details of the COACT trial, over 90% of patients received inopressor, mainly norepinephrine, for 2 days. And based on my calculation, at least somewhere between 15 to 25% received norepinephrine plus dobutamine. So they did not really exclude cardiogenic shock. They may have excluded the most extreme cardiogenic shock in those trials, but that doesn't mean extreme cardiogenic shock post-cardiac arrest with no ST elevation qualifies for urgent cath. In fact, extreme cardiogenic shock may be excluded because the outcome is potentially too poor to benefit from anything. Also, in extreme shock, there is a high risk of recurrent cardiac arrest during transportation to the cath lab or setting up for cath. So again, less reason to do emergent cath in those patients. So what I'm trying to say, even though they say in their inclusion criteria that they excluded cardiogenic shock, I'm trying to prove to you that they probably did not exclude cardiogenic shock, meaning cardiogenic shock post-cardiac arrest is unlikely to benefit from immediate cath. And they excluded it not potentially because of benefit, but because of futility. So post-cardiac arrest, cardiogenic shock, I would still question the value of emergent cath. So I discussed lack of ST elevation, no benefit of cath overall. Now, how about STEMI on post-arrest EKG? Should you do emergent cath on those? The answer is usually yes, but consider 3 factors. The patient should maintain stable blood pressure on stable doses of pressor for more than 20 minutes with no recurrent cardiac arrest as soon as epinephrine wears off, because you cannot do PCI on such patients with ongoing CPR. So you need to make sure they are stable on stable doses of pressor for likely 10, probably 20 minutes before you take them to the cath lab. Number 2, you need to have persistence of ST elevation at more than 8 to 33 minutes after the cardiac arrest, not just ST elevation on the first post-arrest EKG, and I will explain that, and no neurological predictors of poor outcomes. So I will elaborate on each one of those 3. The first one, emergent cath can only be performed in patients who have sustained return of spontaneous circulation, meaning their systemic pressure is maintained for 20 minutes on reasonable and stable doses of vasopressors without the need of chest compressions or recurrent boluses of epinephrine. That's kind of the definition used in TTM2 trial. Except for rare select cases that qualify for ECMO-CPR, where you place ECMO while they are in active cardiac arrest and you do PCI while they are in active cardiac arrest after ECMO placement. I will describe this. This is a small select group that I will describe a little later. The performance of PCI in patients actively receiving chest compression using an external compression device did not improve the grim mortality in one study and is not recommended. Now I will move on to the second caveat, persistence of ST elevation. One study has shown that ST elevation on EKG performed less than 8 minutes after return of circulation has 18.5% false positive rate, meaning you have ST elevation on the EKG, but in 18.5%, you have no CAD on Cath. In this case, this early ST elevation is frequently transient and related to the deep global myocardial ischemia caused by the cardiac arrest itself rather than coronary occlusion causing the cardiac arrest. And that early ST elevation will lead to STEMI overdiagnosis. So ST elevation secondary to the profound global myocardial ischemia. In those patients, you can actually get a transient, diffuse, severe ST depression with ST elevation in AVR. And in that study published in JAMA, performing the EKG at more than 8 minutes reduces the false positive rate to 7%, and performing it at more than 33 minutes reduces the false positive rate to 5.8%. So the bottom line of this, don't go by the initial EKG. You need to have persistent ST elevation more than 8 to 33 minutes after the cardiac arrest. And it's easy to repeat. Repeat the EKG in the ED while you are assessing the patient and while you are potentially setting up for cath lab. 8 to 33 minutes goes by quickly. If ST elevation is not persistent, I would put those patients in the category of no ST elevation and manage them as such. I'll put them in this category with no urgent cath. Now, the third feature I described, I said ST elevation post-cardiac arrest, we take them for cath, but account for sustained, maintained blood pressure, persistent of ST elevation, and no neuro predictor of poor outcomes. And those are the neurologic predictors of poor outcomes. And I classify them in two groups. One, the clinical and cardiac arrest feature, and two, the initial neuro exam features. No one particular feature should exclude you from undergoing cath and from aggressive management. But the more you have of those, the less likely you are to recover neurologically and the worse your prognosis, and the less likely you are to want to be aggressive in management. So older age, more than 80, initial PAA or asystole, especially unwitnessed PAA and or asystole with more than 10 minutes to initiate CPR. So that's the third feature, unwitnessed arrest or delayed initiation of cardiac compression more than 10 minutes, especially if you have PAA asystole with delayed initiation more than 10 minutes, it's nearly certain that the patient will have a very poor neurologic outcomes, maybe close to 100%. Prolonged CPR before return of spontaneous circulation. Remember, CPR provides some brain flow, but CPR at best provides up to 20% of a normal cardiac output. So prolonged CPR more than 20 minutes is predictor of a neurological insult. So remember that number, more than 10 to initiate CPR, more than 20 of CPR before spontaneous circulation, or more than 3 doses of epinephrine required. Low pH less than 7.2 or lactate over 7 or especially over 10 after cardiac arrest. Now, initial neuro exam feature, if the patient is completely unresponsive, but keep in mind, even if he's completely unresponsive, some may recover neurologically if no other bad features, as in COACT and TOMAHAWK, in the range of 40 to 60% eventually survive to hospital discharge with good neurological status. So again, it's one feature out of many. Absent multiple brainstem reflexes and myoclonic seizure. This is a particularly adverse neurologic predictor. Not so much the undifferentiated myoclonic jerks. Undifferentiated myoclonic jerks also are predictive of poor neurologic outcomes, but much less than organized myoclonic seizure. Myoclonic seizure is a very adverse neurologic factor, even by itself, even when it's the only one found. So to summarize, when to do emergent cath after out-of-hospital cardiac arrest? 1, if the post-resuscitation EKG is consistent with STEMI with persistent ST elevation more than 8 to 33 minutes after arrest and systemic pressure is maintained 20 minutes on reasonable and stable doses of vasopressors and favorable neurological predictors of present. all three. If multiple unfavorable neurologic predictors are present in a comatose patient, treatment is individualized and coronary angiography may be deferred even if you have a STEMI on the post-arrest EKG. Based on the sky here, and you can see, even if you have a STEMI on the post-arrest EKG, if you have multiple unfavorable features neurologically, you may defer, so you can individualize. Even though I'll tell you our strategy, we do take them to the Cath lab if they have those two, but keep in mind, you don't absolutely have to if they have really multiple unfavorable neurologic predictors. Now, in the absence of ST elevation, quickly evaluate for non-cardiac causes, respiratory failure, PE, sepsis, bleed, intoxication, intracranial hemorrhage. Take into consideration Q waves to suggest scar VT VFib, because like I said, the most common cause of VFib arrest and cardiac arrest in those patients is usually scar VT, scar VFib. So take into consideration Q waves and take into consideration persistent profound ST depression. Immediate cath is rarely needed in those patients, and possibly consider it if persistent profound ST depression, which is suggestive of severe ongoing ischemia causing the arrest, so persistent and profound, and good neurologic predictor, and cardiogenic shock, but not extremist and not with recurrent cardiac arrest. Patient maintains blood pressure on stable pressors. Another idea here, keep in mind that COACT and TOMAHAWK only had patients who are deeply comatose and completely unresponsive. All those algorithms do not really apply to patients who are awake and responsive after cardiac arrest. And in fact, readily consider urgent cath in patients who are awake and responsive after cardiac arrest, even if they do not have ST elevation, as long as MI is suspected as the cause of their cardiac arrest, such as if their initial rhythm was a shockable VT VFib rhythm, or they have any ischemic EKG, whether ongoing or even transient, or if they have a preceding chest pain. So if they are awake and responsive, we manage them like we manage any acute coronary syndrome, and likely take them urgently if you suspect MI on them. And these are the guidelines. These are the ESC guidelines. They recommend the primary PCI strategy post-cardiac arrest only in patients with persistent ST segment elevation. And they insist on the word persistent, like I did. And these are the SCI guidelines. They are kind of also focusing on the STEMI. Those are the ones that you take urgently. They put cardiogenic shock, but like I explained, I think I disagree. I would only take cardiogenic shock if they have either ST elevation, post-cardiac arrest, or ongoing and profound ST depression. So cardiogenic shock, post-cardiac arrest, immediate cath only if STEMI, or plus or minus profound persistent ST depression with good neuropredictor. Often do not use Impella and other LV support in those post-cardiac arrest patients just because of the questionable value. Danger shock trial that showed benefit in STEMI shock excluded out of hospital post-cardiac arrest, and the ECLS shock trial with ECMO and IABP shock with IABP included post-cardiac arrest patient, but that may be the reason why those were negative trials. They did not show a benefit of balloon pump and ECMO, partly because of those post-cardiac arrest patients. So try to avoid support devices in those post-cardiac arrest patients because of concerns of futility. Impella plus or minus other LV support may be considered only if STEMI with shock and the patient is awake responsive post-cardiac arrest. Usually it would be a brief witness arrest, including VFib during transport or in the ED, as per danger shock trial. Now, is there a role for echo in post-cardiac arrest patients? Echo is valuable to assess the LV and dictate the management of shock and heart failure after cardiac arrest, but it does not help in deciding immediate cath or not. And here are the caveats. Echo post-cardiac arrest often shows a global LV dysfunction that is non-specific, as it may be secondary to the cardiac arrest itself to the post-cardiac arrest, myocardial stunning, or chronic cardiomyopathy. Even if you see segmental dysfunction on echo, it's also non-specific, as it may be acute ischemia, but it may be chronic scar. I mentioned the big cause of VT VFib with no ST elevation on EKG is a scar VFib. So it wouldn't be surprising to have segmental dysfunction. That doesn't mean acute ischemic event. Echo may be more specific in some settings, particularly when segmental dysfunction is present with the following. You have segmental akinesis of a thin myocardium with the Q waves and no ST elevation. This further corroborates an old infarct and scar-related VFib rather than acute ischemia VFib. If you have segmental akinesis without Q waves, especially with ST depression, that would suggest acute ischemia. If you have preserved LV function with akinetic or dilated RV, that suggests PE, massive PE. If you have preserved LV, that suggests either non-cardiac cause of arrest or in a young patient, cardiac cause from channelopathy. So preserved LV can also help gear you toward what etiology. Hypothermia in comatose post-arrest patient. The temperature goal is 32 to 37.5 degrees Celsius within 6 hours after return of spontaneous circulation and maintained for 24 hours. Two modern trials, TTM and TTM2, showed that the mere prevention of post-arrest hypothermia with a low normal temperature of less than 36 in TTM trial or less than 37.5 in TTM2 is as effective as a temperature goal of 33 degrees Celsius, which was the comparative arm in those trials, and which was the target used in the two old landmark trials over 20 years ago. So the updated recommendation is up to 37.5 degrees Celsius based on that TTM2 trial. And you may use surface cooling devices or intravascular cooling devices using endovascular cooling catheters. And those are the recommendation in the ACLS 2023 guidelines. We recommend maintaining a constant temperature between 32 and 37.5 during post-arrest temperature control and maintained for at least 24 hours. And kind of the same in the 2023 ESC guidelines. Note that in TTM2 trial, even in the arm where the target temperature was 37.5 degrees, cooling devices were required in 46% of patients, which highlights that we frequently need active measures to prevent hyperthermia in cardiac arrest patients, and we frequently need cooling devices even when we're only aiming for normal temperature. There are a couple more ideas I want to address. How about long-term ICD for survivors of cardiac arrest? And the answer to that is split in three. One, the group of patients with STEMI on post-arrest EKG. Two, the group of patients with no ST elevation on post-arrest EKG, but they have CAD on Cath. And three, they have no ST elevation on post-arrest EKG, and they have no CAD on Cath. So the first group, they have STEMI on post-arrest EKG, and you find an acute coronary occlusion on Cath. Those patients do not usually need an ICD, simply because we know VFib within the first 24 hours of STEMI does not predict a long-term risk of recurrent VFib and sudden death. The second group is more tricky. So you have cardiac arrest, you have no ST elevation on the post-arrest EKG, but you find CAD. For that group of patients, you often need an ICD. So the answer is often yes. You certainly need it if on your Cath, you do not find any acute lesion or anything that you consider an acute lesion, especially if you have underlying Q waves and prior akinetic or dysfunctional myocardial wall. Because in that case, you very strongly suspect that this VFib or VT arrest is due to a scar old CAD and scar from old CAD. It's a scar VFib. It's a little more tricky if no ST elevation, you cath them, you find CAD that you think is acute. Those lesions over 70% with irregular features, eccentric, overhanging edges, a thrombus. Those are more tricky. But even in that case, we generally favor ICD placement if you did not have ST elevation, simply because it's hard to ascertain that VT, VFib was due to coronary event versus chronic scar from that underlying CAD that you're seeing. It's hard to ascertain that what you're seeing is really an acute lesion versus a chronic old CAD with maybe some underlying myocardial scarring. Maybe the only times I would consider not putting an ICD in those patients is if you have on the post-arrest EKG profound ST depression that persists. So you have persistent profound ST depression early on, along with severe troponin rise in the type 1 MI range, in the definitive type 1 MI range, such as HS troponin T in the thousands or HS troponin I in the 10,000. And you can consider doing an MRI in those patients. And if the MRI does not show any scar, then that will argue against ICD. So that combination of big MI by profound ST depression, along with very high sensitivity troponin and no scar on MRI, could gear you away from ICD in this group of patients. Otherwise, overwhelmingly, when you don't have ST elevation on the post-arrest EKG, you overwhelmingly need an ICD. Certainly, if you don't think there is an acute lesion on Cath, even if you have significant lesion, 80% stenosis of an OM or RCA or LAD, but you don't think it has acute features, or even if you think it has acute features, and that could be the only exception here that I highlight here, where you may not place an ICD. Now, the third group of patient is the one where you have no ST elevation on the post-arrest EKG, and you have no CAD at all. That is a group I'm going to discuss now, but that group overwhelmingly, yes, needs an ICD. Now, let's discuss that group. So you have VFib arrest with no STEMI on the post-arrest EKG, and you cath them, you find no significant CAD. What are the causes of that VFib arrest, and what's the workup? And this is this group here. So 2/3 of patients with VT VFib arrest have no ST elevation on the post-arrest EKG, and 35% of that 2/3 have no CAD at all. So what are the causes? There are two major categories of VT VFib here. One is cardiomyopathy, so underlying structural myocardial disease, non-ischemic, such as dilated cardiomyopathy, hypertrophic cardiomyopathy, or valvular cardiomyopathy. The second big category is no cardiomyopathy at all. Perfectly normal myocardium, but you have a pure electrical problem, such as channelopathies, what we also call SADS, sudden arrhythmic death syndrome. So those are the two big categories. A smaller and less common category would be coronary epicardial vasospasm with a transient severe myocardial ischemia and VFib arrest. Frequently also transient STEMI in that group of vasospasm. And the prevalence of each one of those two categories depends on the age. So if you take patients over the age of 35 with no CAD, what's the cause of VT VFib arrest in them? Dilated and hypertrophic cardiomyopathies or severe valvular disease. It could be electrical cause, the sudden arrhythmic death syndrome, but it's less common than in the less than 35 years old. So in patients less than 35 years old, you could have a sudden VT VFib death from structural heart disease or from those electrical causes. And the electrical causes explain up to 40% of sudden death at this age. So the structural cardiac causes at this age, less than 35, and at an older age range are hypertrophic cardiomyopathy, it could be ARVD, it could be cardiac sarcoidosis, myocarditis, some form of dilated cardiomyopathy that are particularly prone to VT-VFib, such as Lemon AC cardiomyopathy or the genetic LV non-compaction. You could also have aortic stenosis, valvular disease due to bicuspid aortic valve, which can manifest at an early age. You could also have coronary artery anomalies and coronary vasospasm. Now, some of the electrical causes at this age range and at an older age range are long QT syndrome, Brugada syndrome, idiopathic catecholaminergic polymorphic VT, CPVT, idiopathic VFib, including the idiopathic VFib that occurs in patients with malignant early repolarization, and very early PVC in patients with malignant early repolarization. You have the short QT syndrome, WPW, cocaine use, and commotio cordis in athletes who get blunt trauma to the chest during T-wave. And how do you work up those patients with VT-VFib arrest and no CAD on Cath? This is a general approach regardless of age. So you perform coronary angiography and echo to look for structural disease, and you analyze the EKG for subtle signs of electrical causes. In those without CAD and without obvious structural disease on echo, or with only transient LV dysfunction, perform the following test, looking for subtle structural heart disease and looking for electrical causes. So after you've ruled out by Cath, echo, the major structural heart diseases, then you do workup for subtle structural heart disease, such as subtle ARVD and sarcoidosis and myocarditis, or subtle subclinical genetic cardiomyopathy or LV non-compaction. So you do workup for those subtle structural causes, and you do workup for the electrical causes. And this is how I'll put the workup. EKG stress testing in an effort to unveil long QT syndrome 1 or CPVT. You do intravenous procainamide testing in an effort to unveil Brugada pattern. If it's not obvious on the baseline EKG, you can also do high recording of leads V1, V2, place them at the second intercostal space to unveil Brugada pattern. If it's not obvious on the baseline EKG, then you can do that provocative testing with procainamide. Do advanced imaging with cardiac MRI and chest CT looking for ARVD and sarcoidosis. Consider coronary angiogram with provocative testing with intracoronary acetylcholine to provoke for vasospasm, especially in patients who show dynamic ST changes on telemetry monitoring or those with evidence of an infarction pattern on cardiac MRI, or who have marked troponin elevation over 1,000 for troponin T or 10,000 for troponin I, yet no CAD on Cath. And if all the above is negative, consider targeted genetic testing for channelopathy, including for concealed negative phenotype, Brugada, and long QT syndrome, keeping in mind that the yield for genetic testing for those channelopathy is low. Eventually, regardless of what comes up of your workup, all those will require an ICD, even patients with coronary vasospasm. The sudden death from coronary vasospasm is dramatically reduced by calcium channel blocker, but it's not fully eliminated based on 2 registries. So even coronary vasospasm with sudden death will require an ICD. So all those will eventually require an ICD, regardless of what the eventual etiology is. I want to mention one last idea here about that narrow subgroup who can qualify for ECMO and CPR while the cardiac arrest is ongoing. I mentioned that PCI is futile in patients who are actively undergoing cardiac compression, but a select group of those patients undergoing active cardiac compression with a Lucas device, whose initial rhythm is VFib and who have refractory VFib arrest, may qualify for emergent ECMO placement while undergoing consistent CPR with Lucas device. In those patients, you place ECMO emergently, whether in the emergency room or the catheterization lab. That ECMO will provide organ and cerebral perfusion, and after you place it, you perform PCI while the patient is in cardiac arrest but being supplied by the ECMO. And this is considered in the patient with the following 4 features. One, it has to be a witnessed VFib arrest that is refractory to 3 shocks and amiodarone. It's okay if it has evolved to PA asystole post-shocking the VFib. 2, it's usually a witness arrest with near immediate initiation of bystander CPR. The resuscitation has to be ongoing for less than 45 minutes, and the estimated transfer time from the field to the cath lab, less than 30 minutes, and younger age, less than 75. So know those features. It has to be a refractory VFib arrest, refractory to 3 shocks. It could have evolved to PA asystole. Younger age, time to transfer from field to cath lab, less than 30 minutes. Overall resuscitation ongoing for less than 45 minutes. And we are starting to implement this at our institution. And this is based on work by the University of Minnesota group. Notice, for example, in this paper in Lancet, they recruited for that protocol 30 patients over the course of a year. So it's a very select group of patients. And I'll show you a case done here by our colleague, Dr. Rosen. So this is a 64-year-old man. He had a history of anterior MI in 2013 with ICD. He presented with posterior MI and 2 ICD shocks. In the ED, he developed a witness cardiac arrest from a refractory VT VFib that was refractory to many shocks and drugs while in the ED. So it's a refractory VT VFib witness in the ED with ongoing CPR. So Dr. Rosen took him emergently to the cath lab for ECMO cannulation while he was having ongoing VFib and CPR. And after placing the ECMO, they did coronary angiogram while ongoing ventricular fibrillation. And this is the angiogram during VFib after the patient has been cannulated with ECMO. And you can see here he has an occluded left circumflex, which is a culprit for his infarct. And he also has severe thrombus in his proximal LAD. So what they did, they stented the left circumflex and they ballooned the LAD. They obtained a good result. And at the end, after left circumflex and LAD PCI, which was done while he was in VFib with the ECMO support, at the end, after the PCI, he was successfully defibrillated finally, and he gained sinus rhythm at the end of the PCI procedure. Now, we had a long and complex hospital course. Later on the same day, patient underwent Impella CP placement for LV venting. Remember that ECMO is great for end organ perfusion and systemic perfusion, but it dramatically increases LV afterload, and the LV may balloon and dilate, particularly that the LV still gets venous return from the bronchial veins and the Tebesian veins. So in patient with absolutely no intrinsic LV function, as evidenced by on echo, you see absolutely no opening of the aortic valve, or on the arterial waveform, they are flat. They have no pulsatility, especially no pulsatility over 20 millimeters of mercury. This indicates that that patient has no intrinsic LV contraction. Add to it the high afterload from the ECMO, their LV will keep ballooning and they will never recover. So those patients with ECMO, with absolutely no intrinsic LV function and with no pulsatility, no aortic valve opening, you need to vent that LV, unload that LV. And this is commonly done with Impella. It can be done with balloon pump. It can be done with left atrial septostomy. But anyway, here Impella was placed for LV venting. Then eventually 5 days later, he underwent Impella 5.5 placement for LV support. He was weaned off ECMO 7 days later while Impella 5.5 in place. He was intubated for a duration of 2 weeks. The good news is that despite that prolonged cardiac arrest, he had full neurological and mental recovery. The issue is his LV never recovered. It remained poor. Impella 5.5 placed via right subclavian was kept in for 5 weeks and could not be weaned off. Eventually, he underwent durable LVAD HeartMate 3 placement 5 weeks later. But he survived with good neurological recovery.